Hello everyone. Today we'll discuss about tuberculous meningitis. Tuberculous meningitis is an important topic in your Viva session in NEET PG entrance and also in your theory exam. Okay. Here we'll discuss about its pathogenesis, its clinical features, the stages of occurrence, and also the investigations and management. So starting off with the introduction, it is one of the most serious complication in the children. It is one of the most serious complication in children. Next, the age group of occurrence. So the common age group of occurrence is between 6 months to 4 years. Next, it can occur at any age. So this age group was found according to many recent guidelines and from many research papers, since the child with the 6 months to 4 years are more potent for tubercular meningitis, they have given as a common age group, but the tuberculous meningitis can occur at any age. And they have the progression can be rapid progression also, it can be slow progression also. So this depends on the immunity of the child and the virulence of the bacteria. Next, going on with the pathogenesis of the disease. So the pathogenesis, everybody knows that tuberculosis is mainly acquired by respiratory droplet, that is respiratory route. Okay. So the primary focus will always be in the pulmonary. So the primary infection is always the pulmonary focus. The pulmonary focus is called as Ghon's focus. From pulmonary, it spreads through a lymphohematogenous route. So it spreads as lymphohematogenous spread. From lymphohematogenous, it goes to the brain, that is mainly to the cerebral cortex, or it can go to the meninges. It goes to cerebral cortex or in the meninges. So this forms a focus called as rich focus in brain. It forms a called rich focus in brain. It is pulmonary focus is called Ghon's focus. In brain it is called as rich focus. We'll make a shots in tuberculosis where all it forms focus. Okay, there are many focus. In liver we have one focus. In lungs it is one focus. In brain, in meninges. Okay, so we'll make one shots in that. Okay, so the rich focus, it increases in size. First, naturally, the initial lesion will increase in size. After the size gets increased, this will discharge the tubercle bacilli into the CSF, that is in the subarachnoid space. So, this tubercle bacilli is discharged into the subarachnoid. It is discharged into the subarachnoid space. Okay, in subarachnoid space, this tubercle bacilli, it is a very rich in protein, so it will form an exudate. So that exudate will be gelatinous in nature. So this gelatinous exudate will infiltrate the blood vessels. So gelatinous exudates will infiltrate the blood vessels. Once it infiltrates the blood vessel, it causes inflammation, obstruction of the blood vessel. So once the blood vessel is being obstructed, it leads to infarction in that particular cerebral cortex where the blood vessel supplies the brain. Okay, it forms a infarction in the cortex. Okay, this obstruction is not only in the blood vessel, but this obstruction can also be in the arachnoid villi granulations. Since the obstruction is also present in the arachnoid villi granulation, this can lead to what it is called as communicating hydrocephalus. So in a previous video we have discussed about hydrocephalus, that is communicating hydrocephalus and non-communicating hydrocephalus. So the communicating hydrocephalus is when the absorption is poor. When the absorption is mainly through the arachnoid villi granulations. When that is poor, it leads to communicating hydrocephalus. While the obstruction is in the ventricular system, that is between the lateral and the third ventricle, or between the third ventricle and the fourth ventricle, when there is an obstruction in the pathway, it leads to non-communicating hydrocephalus. Okay, this is about hydrocephalus. Next main important part is brainstem. So brainstem is the site of greatest involvement. So this can be one of your PG entrance question or in your Viva session. Okay. So this brainstem is the site of greatest involvement. So site of greatest involvement. So this can lead to dysfunction of the cranial nerves. So the cranial nerves specifically involved in tuberculosis. So this can lead to dysfunction of the cranial nerves. The specifically involved in the tuberculosis are cranial nerve 3, 6 and 7. This is also one of your important Viva question and also in your NEET PG. So the main part of the brain that is involved in tuberculous meningitis is brainstem. Among that, the cranial nerves involved is 3rd, 4th and the 7th cranial nerve. Okay. So this is about the pathogenesis of this what is called tuberculous meningitis. Next we will see about the clinical features. In clinical features we have 3 stages. So clinical features has been divided into 3 stages. In that stage 1, it is in the stage 1 the child will present with non-specific symptoms. So the stage 1 the child will present with non-specific symptoms and the stage can last for 1 to 2 weeks. Fine. So the non-specific symptoms that is present in the stage are, one is fever, headache, anorexia, malaise, inadequate weight gain or weight loss. So the child can present with inadequate weight gain or weight loss. Plus, main important point is the child can present with stagnation or regression of developmental milestones. So another question, in which stage of this tuberculous meningitis the child can present with stagnation or regression of developmental milestone? It is in the stage 1, not in stage 2 or stage 3. It is mainly in the stage 1. Next, the symptoms in stage 2. So the symptoms that is present in stage 2 are signs of raised ICP. So signs of raised ICP is, I'll tell you, it's Cushing's triad. Another triad, okay? Remember this. So Cushing's triad here is, it involves hypertension, that is increase in BP, irregular respiration and bradycardia. This is the triad of Cushing's reflex triad present in raised ICP. Plus the child will have signs of meningeal irritability. The signs of meningeal irritability are neck rigidity, Kernick's sign and Brudzinski sign. Kernick's and Brudzinski. Nuchal rigidity, that is neck rigidity. So everybody knows this Kernick's and Brudzinski sign, no? Okay, I'll explain it here. So Kernick's sign is when you flex the neck. When you flex the neck of the child will have an involuntary flexion of the hip and the knees. That is called Kernick's sign. Next, Brudzinski. Sorry. I've changed. This is the way everybody will change the Kernick's and Brudzinski sign. Sorry. So Brudzinski sign is when you do a passive flexion of the neck, the child will have flexion of the hip and the knees. This is Brudzinski sign. Kernick's sign is when the child is lying down when the hip is in the flexed position and knee is also in the flexed position, when you passively extend the knee, the child will resist. That is, resist in pain. That is called as Kernick sign, and this is Brudzinski sign. Okay, so when the passive flexion of neck, there will be flexion of hip and knee, that is Brudzinski sign. Kernick is extension of the knee. When passive extension of the knee can cause pain in the child and the child will resist. That is called Kernick sign. So these are the signs in the what is it called as meningeal irritability. Next, the child can also present with cranial nerve palsy. So the cranial nerve palsy is present in stage 2. Fourth, seizures. Fifth is hypertonia. These are the signs and symptoms that are present in the stage 2 of this tuberculous meningitis. Next, in stage 3. In stage 3, the child will be presenting in coma stage. The child can have hemiplegia or paraplegia. The child can have decerebrate posturing or decorticate posturing. So these everything be present. The terminal stage is stage 3. The prognosis also depend upon these stages. Okay, so I'll start here. I'll tell about the prognosis also here. The prognosis is how you give the treatment, in which stage you give the treatment. When the treatment is started in the first stage of the illness, the child, the improvement in the child will be more compared to the treatment given in the third stage. So prognosis will correlate mostly with the clinical stage. So the prognosis will correlate with the clinical stage of illness at the time of treatment. Okay, so this is about the what is it called as this one, clinical features. Next we'll go on to the investigations. In investigation, the initial modality of diagnosis is CECT. So the initial modality of diagnosis is CECT brain. In CECT, what are the features the child can present with? So in CECT, the child will mainly present with basal meningeal enhancement, second, the child can have features of hydrocephalus. Third, infraction. Fourth, the child can have features of tuberculoma also. Fine. This basal meningeal enhancement is main point, because in tuberculous meningitis, I have already told in the pathogenesis that the child will have a gelatinous exudate. That exudates will be very thick. That will cause the basal meningeal enhancement. That is the main point you have to see in a CECT of a child when you suspect a tuberculous meningitis. When in CECT it is inconclusive, in CT if it is inconclusive, then you have to do MRI is preferred when the CT is inconclusive. Okay, fine. Next, CSF findings. Next you will do LP in the child. So in the LP you have to do CSF findings. The CSF finding in tubercular meningitis are: the fluid will be very clear, but the pressure is increased. Next, the cell count will vary from 10 to 500 cells per cubic millimeter. Among them, lymphocytes will be the major amount will be present. Okay, lymphocytes will be present mostly. Next, fourth point, the protein here will be more than 100. Protein is highly elevated. This is one of the specific feature, will be very highly elevated. While in bacterial meningitis, protein will also be elevated, but protein elevation will be higher when compared to bacterial meningitis. Okay, glucose will be low, that is less than 40. That is normal is 40, less than 40 milligram per deciliter. CSF glucose by blood glucose level will be less than 0.5. Okay. On long standing appearance, you can see a cobweb appearance of the CSF. Okay. So these are the CSF features in a child with tuberculous meningitis. Next, the similar findings, that is similar findings in the imaging, can also be present in other disease. So the DD, that is differential diagnosis, you can also suspect other infections like similar radiological findings with similar radiologic, like basal meningeal enhancement, hydrocephalus infarction. Okay, these are cryptococcal meningitis, second CMV encephalitis, third in toxoplasmosis, next in sarcoidosis, fifth in meningeal metastasis. So these are the findings in differential diagnosis for the similar radiological findings. One is cryptococcal meningitis, next will be CMV encephalitis, another is toxoplasmosis, sarcoidosis and meningeal metastasis. Fine. Next, going on to the approach. How you are going to approach when you suspect a child with the tuberculous meningitis? So when you suspect a child, so suspect tuberculous meningitis if the child has headache, vomiting, irritability, lethargy. Third, when the child presents with seizures, confusion, coma, neck stiffness, cranial nerve palsy, that is mainly 3rd, 6th and 7th cranial nerve palsy, you have to suspect the child to have tuberculous meningitis. Fine. Next, you have to do immediate investigations to be done. So immediate investigations are chest X-ray, TST, that is tuberculin skin test, that is Manto. Next, HB, LFT, these are normal investigations. RBS. Next, main initial investigation of choice is imaging, that is CECT brain. Next, you will do lumbar puncture to do the CSF analysis. In CSF analysis, you will do you will see for AFB, that is acid fast bacilli. You can do CB NAT.